Okay, well, good morning, everyone. It is just about 11 o'clock, and I want to be honoring of everybody's time. I do want to let you all know that we do have this session recording, so that we'll be able to provide that recording for individuals who aren't able to make any of the training times. My name is Tammy Scott, and I am with the Early Learning Division. And Dr. Thomas, can you introduce yourself?
Hi, I'm a public health physician in the Acute and Communicable Disease Program at the Oregon Health Authority, and naturally, I've been detailed to the COVID response unit of late.
So thank you for joining us today. We're really excited to be able to establish this telehealth line for our childcare programs. It's been really a missing link during the pandemic. Right now they call our licensing specialists when they need the advice, or they call the local public health authority, which I think has been pretty overwhelmed with the quantity of cases. And our licensing specialists certainly don't have the medical expertise to be answering some of these questions. So we're really excited to be establishing this partnership with OHSU, and we appreciate you taking some time with us today. And I think there's a pretty good chance that we'll get done much quicker than an hour, depending on how many questions you have. Dr. Thomas is going to be presenting the majority of the information, although I will jump in on a couple of the slides, and I'll help monitor the chat log. But there's only a few of us on this call, so I think it's also fine if you take yourself off mute if you want to ask the question also. So with that, we will jump in. So childcare providers in the state of Oregon have been under some health and safety guidelines during the pandemic. These guidelines were established and sent out last year in September, actually August 14th, and then implemented in September. And since then, we have made some updates as we've learned more about the virus and as things have grown and changed. So I did want you to just have a general understanding that there's actually like a 60-page document that covers things such as PPE, having stable groups in their childcare, transportation, daily health checks, and how to respond to confirmed or presumptive cases of COVID. But for the purposes of today, we're going to focus just on those sections that we anticipate you'll get questions about. So first I wanted to do a little bit review on like who is a childcare provider? Who do we anticipate will be calling you? And childcare in Oregon looks, in several different ways. We kind of have three big buckets. One is we have childcare centers, which is kind of the traditional kinder care that you think about, or the YMCA has a lot of childcare up in Portland. So it's a childcare center, and you'll probably be getting calls from their director of the center, and the director might be calling about staff that work for them. So maybe a staff is presenting with some symptoms and they'd like to tease it out, or they could be calling about children that are enrolled in their program. And when they're calling about children enrolled in their program, the questions could also extend into the family members, such as, this child's parent tested positive 2 days ago. So, that's about as far as we anticipate those relationships would be going. In Oregon, we also have a pretty big supply of family childcare providers. These are providers that have a business in their home, caring for a maximum of, with one type of license, it's 10 children. With another type of license, they can have up to 16 children. And they could be calling about their childcare staff, because some of them do employ staff. They could be calling about children that are enrolled in their program, but they could also be calling about their own family members that live in the childcare. So they might be calling because their son came home and they found out that their son's friends' parents were exposed to COVID and the son had been in their home, and they're wondering how that affects their childcare. The other category of childcare that we have in Oregon is what we call family, friends, and neighbor care. This is an informal type of care, and they're individuals who do care for children who are eligible for employment-related daycare subsidy through Department of Human Services. Oftentimes, these are relatives. I know that there are about 3,400 family, friend, and neighbor care providers that Department of Human Services pays subsidy to support the child care need. And we know that there's 1,700 FFN providers, not 3,400. And out of the 1,700, 1,100 of them are some form of relative care. And then in terms of our licensed providers, there's about 3,400 across the state. So between those two categories, you're looking at just over 5,000 programs that could potentially be calling. And the telehealth line is not meant for the families that are using the child care services. So we're going to make that clear in the information that we put out to providers that this is really for child care programs to call you, not for their families. Dr. Thomas, do you have anything to add on that?
No, I think that was a good description of the program.
Okay. And then the only other thing that I'm going to touch on before I turn it over to Dr. Thomas is that right now in that document that I described, that's about 60 pages long, we do have a daily screening process that is required for childcare programs. So prior to anyone entering into the program, whether it's children, staff, volunteers, or other adults, every single day, every time they enter, they have to do a temperature check. And they can do that by using an actual thermometer, or they can rely on a verbal report. They ask about other COVID symptoms such as shortness of breath, cough, fever, loss of taste or smell. And then they also ask every day if there's been any contact with confirmed or presumptive cases. These are pretty standard questions that we all know are happening in most medical facilities, and it's happening in childcare. And then they are required to maintain records of attendance and documentation of doing those daily health checks. And maintaining those records is, of course, really important when it comes time to do contact tracing if there is a known case. Okay, now I'm going to turn it over to Dr. Thomas.
Thank you. And I'm just sort of wanted to add that I'm really happy that you're all here, and we're really looking forward to this partnership. I think we'll be providing a very useful service to child care providers in the state. So I want to let you know about the symptoms that we use for screening children to exclude them. Of course, this list of fever, cough, shortness of breath, new loss of taste or smell does not include every possible symptom of COVID, but we sort of landed on these as the ones that are most predictive of having COVID, because of course, certainly children could, we do hear about cases where someone presents solely with, gastrointestinal symptoms like vomiting or diarrhea, but, without, the cough or the fever, the odds are still higher that they have, viral gastroenteritis due to something like a norovirus. And we don't want half the children, we don't want, any child that has vomiting or diarrhea to be excluded for the full time. That's why you might think that this list is smaller than what you've seen as the potential symptoms that could cause COVID. The other thing that deserves a little explanation is what we call an unusual cough. And what we mean is, really it means an acute cough, a new cough, and it's different for this person. So in some cases where a provider has been taking care of a child for a year or two and knows that this child has asthma, and this child really seems to be at baseline, or if it's a child where the parents know that they have allergies and they know that it's typically this time of year, and the child is responding to their usual medications, we would not insist they go home. But really for anyone otherwise that has a new cough, they would have to be excluded. And I think we also are kind of from a public health standpoint, we're sort of not asking you to make a decision about, oh, does this cough look like COVID, or is this child well enough to stay in child care? Really, if you have any one of these symptoms, you feel like the predictive value, the chance that you have COVID is high enough that the child needs to be excluded. So even a child that looks pretty well, but is having a cough, needs to be sent home. And typically kind of our basic mantra is for someone who is symptomatic with COVID is that they would need an adult or a child would need to be excluded for 10 days and until they have at least a 24-hour period where they're free of fever without taking a fever-reducing medication. And the cough doesn't have to be fully resolved, but it certainly has to be improving. The key thing we're looking for is absence of fever without antipyretic medication. Next slide, please. Now, in terms of, once a child has been sent home from childcare, we would urge them to get tested. Not everyone has access to that, but certainly if they have a negative COVID-19 test And we would allow either a rapid test or a PCR test, anything that's, approved and approved under an emergency authorization can be used. If they have a negative test, they can come back. And of course, we still want their symptoms to be better, but at that point, it could be treated more like, a common cold when this, again, they might only have to stay home for 2 or 3 days, but we want that fever resolved for 24 hours without taking any medication, and we want the cough to be improving. Otherwise, if they have a positive test or if they're unable to get a test done, we would presume that they have COVID and they would need to stay away for the full 10 days. Kind of an exception to the rule that you can't come back unless you have a negative COVID test is in settings or a scenario where the only symptom is fever. And in that case, since it could be due to a UTI or something, some other cause of a fever, a medical professional can, see the child, come up with, if they have an alternative diagnosis that the provider feels is not COVID, then once that child is fever-free for 24 hours, they can come back. And that's really the only time when you could come back without having a test. The other thing is, I think for those of you who are parents and have had children in daycare, you know that, they're pretty quick to call you when the child has vomiting or diarrhea or pink eye, or any, fever, rash. They have, we have a handbook, OHA has a handbook for them, and they sort of know which common childhood diseases, children need to be excluded from childcare for, and they're still, looking out for those. But we wanted to make clear, I think particularly with vomiting and diarrhea, which are so common, that as long as they don't have fever or cough, you don't have to assume it's COVID. They could be treated like, kind of the normal regimen 2 years ago. If a child had vomiting or diarrhea, they'd be sent home. If the parents felt they were sick enough to seek care, that would be great, but we wouldn't necessarily require a note for them to come back. We just want them to be symptom-free for 48 hours before they return. For others, obviously a headache with a stiff neck, we would want them to see a provider and rule out bacterial meningitis. But for most of these other common conditions of childhood, they could return 24 hours after they're free of symptoms. Next slide, please. So I think one thing that will come up is you'll be asked also to weigh in on if, because the other screening thing is in addition to the child or the staff member's symptoms, they will be asked if they have been exposed to anyone with COVID. And so the first thing we have to think about is really defining what does an exposure look like. And we say that's contact of less than 6 feet for longer than 15 minutes in a 24-hour period. And that's regardless of use of face coverings, particularly since in most of these settings, people could be wearing cloth face, homemade cloth face coverings or something they bought at Target. And, if they're closer than 6 feet for longer than 15 minutes. And this will come up, kind of the settings where this will come up is, for the most part, children in a childcare cohort, they'll stay with their same group all day. And we don't require children under the age of 5 to wear any face covering. So typically, if there's been a case in a staff member or a child, it is often pretty much automatic that whole group of children and the staff will need to stay home for a quarantine period. But where it will kind of come up and where you might be asked to field questions is, well, what if the person who is sick is a staff member who floats between different classes during the day? And I think in those settings, we might allow that person, of course, the person who is sick will go home, but you wouldn't necessarily have to quarantine the whole class if most of the contact was with another provider, or if maybe, the floater was kind of working with one kid to help them tie their shoes or wash their hands and was closer than 6 feet, but you probably wouldn't have to quarantine the whole room. I think the other time it might come up is in a setting where, you're doing the screening in the morning, you ask about, the child is about to enter daycare, have they been around anyone? And they'll be like, we had a family member, in our house last weekend who turned out to have COVID. But it's worth kind of exploring what the contact was between the child who's entering daycare and maybe this visitor to the household. So if the visitor to the household had a cup of coffee with the mom inside while the kids were all playing outdoors, it wouldn't be a contact. So it's good to ask those questions. The other thing that will come up is to really think about the infectious period. So for COVID, you're infectious for 2 days before the onset of symptoms and up to 10 days afterwards. Because and it's important to take that into account when you're asking about these exposure situations, because we found for a while that children were being excluded unnecessarily because they would someone would ask at the screening on Monday morning, oh, has your child been around anyone with COVID? And they would say, oh yeah, they played with their cousin last weekend. But then it would turn out that the cousin had COVID a month ago. So it's good to kind of sort these things out. If a provider calls you and said, oh, they were exposed, but we're not sure about these dates, it's helpful to be able to know to kind of go over the dates with them. So in general, if it does look like a person meets the definition of an exposure and they were exposed to someone while that person was infectious, then this child or staff member would need to quarantine for 10 days from the last contact during the infectious period. Now we're saying 10 days. I mean, CDC does have new guidelines that say that the quarantine could be shortened to 7 days if the child has a negative test between days 5 and 7 of their quarantine and they haven't developed any symptoms. And so in some cases that will happen. It's often hard for people to obtain a test right on a specific time period. I suspect it's probably easier for children of healthcare workers to obtain that test. But what we're telling people is that even though you would be allowed back in after 10 days or after 7 days, if you have a negative test, that person still needs to be monitoring themselves for symptoms and would need to be excluded if they did have COVID symptoms on day 8 or day 9, for instance. Next slide.
Dr. Thomas, can I do a question real quick?
Sure.
So a question in the chat box is, can quarantine be shortened if they had symptoms early on?
So what happens if I understand the question right, it's like you're exposed to someone, you go into quarantine, and then say on day 2 or 3, you have symptoms. If that happens, at this point, now you kind of start fresh. This is a person who had a contact and has symptoms of COVID. We would, if they have one of those symptoms that we've discussed, we would consider them a presumed case of COVID. So now the clock starts fresh. They're out for 10 more days from the onset of their symptoms.
Yeah, and I'm just going to jump in as a commoner lay person who's had to learn all this. When talking to my staff about this, what I try to help them remember is to separate quarantine because you've been exposed to someone with exclusion because you've now become symptomatic. So you might start out in quarantine, but when you start getting those symptoms, then you jump into the exclusion category for those 10 days.
Yeah. Okay. Anything else?
Yeah, or it says, or are you only referring to those who didn't seek testing rather than those who tested positive and are isolating? And then she indicated that he indicated that he does think he understands it. So I think we're good.
Okay.
Okay. Next slide.
Okay, now this is the big exclusion summary chart. And basically, this is the information that we've just covered. So I won't go over it now in detail, but it kind of has all these scenarios on one page. And the providers also have this and they like it. And this might be the first thing that you bring up on your computer when you get these questions, because it's kind of all sorted out. So for instance, the first column is what to do if a child or staff member has illness with a fever, cough, new loss of taste or smell or shortness of breath, and they should be sent home. If they test negative, they could come back. Otherwise, if they test positive or don't get tested, they need to stay away for at least 10 days. And then it also covers the scenario of if the only symptom was a fever and a doctor has a note saying they can come back after they've been better for 4 to 24 hours, that's how to do it. The next column is if you've been exposed to someone with a current who's a presumptive or a positive case. And in this case, they need to be excluded for at least 10 days of quarantine. And I think we actually have an FAQ on this, but I did see it come up, is that the key thing is you have to count, the quarantine is 10 days from the last time the person had contact with a presumptive case. So that can be, so like if they were in childcare and they were last exposed to another kid in childcare on a Friday, and then everyone goes home, then that Friday was their last day of the quarantine. But if it's a household member who they can't avoid seeing, that household member is going to be infectious for 10 days. So the child's quarantine doesn't start until like those 10 days are up, and then the child's quarantine starts. So that's at least 20 days. And if you have a household of people where people might get it at different times, you keep moving the quarantine back, and it can be like a month or more that a child might be, a child or a family member might be subject to quarantine. The next column is what if a person develops the signs or symptoms, or they've been exposed while at the facility, then they separate that person until they can leave the, so if a child passes the morning screening, but then starts having a fever later in the day, they need to be, ideally put in a separate room, a provider watching over that child, but to keep them, minimize its contact with other children and staff as much as possible. The next scenario is if a child or staff member has a household with symptoms of COVID-19, but who has not become a case yet, they haven't been tested. At that point, it's hard when someone hasn't been confirmed as a COVID case. They've been exposed to someone that has COVID symptoms, but that person's not a confirmed COVID case. We would then monitor the exposed person carefully and try and track each day if the ill household member has been tested, but we wouldn't make that child stay home yet. And then the last thing is just a reminder of like, yeah, other childhood illnesses are still happening, and these are the rules for dealing with those. Does anyone have any more questions about this diagram before we go on?
No, Dr. Blaschke, and I hope I pronounced your name correctly, did make some comments about, and I think he's referring to when you have continuous exposure within a household, how that
Right.
date of quarantine continues to change as you continue to have that exposure.
Yeah, it's kind of a rolling quarantine. Anytime someone has, anytime a family member has, is diagnosed with COVID, or once anyone else gets symptoms, then they're a presumptive case of COVID. They have to go through their full 10-day isolation before other family members can really technically start their quarantine. So it's that people might go through very extensive periods of quarantine if there's, continuous spread within a household,
Right.
which is very unfortunate for families, but that's how we're the best way to handle it for now.
Right. And I've shared with Dr. Thomas and other people that my family had COVID, and there's 5 of us, and I was the last one to get it. So by the time I went through quarantining and everything with it was like the whole month of November was gone because it just kept rolling and rolling. Okay, next slide. So we're going to go through some questions that we receive a lot from childcare providers. And I think the point that I want to make sure that you guys feel supported in is the second part of this answer. So we'll go through this real quick. So if you have a sibling or a parent of a childcare child test positive, does the entire class need to quarantine? And really at this point, the childcare child has to quarantine because they have had exposure to their sibling or their parent. But the entire class does not need to go into quarantine because the child is not symptomatic. If the child becomes symptomatic or tests positive and they were in that childcare class during the infectious period, then that's when the class would have to go into that quarantine. And I think what I want you guys to feel supported in is that when you start getting questions about does an entire class have to shut down, those questions should be directed to our licensing specialist and to the local public health authority. because we aren't expecting you to tell childcare programs, nope, you have to close everybody and send everybody home. Your role is more to help them determine the infectious period and who may have been exposed. Dr. Thomas, anything to add on that?
I would just add that, again, it's not up to you to call the ELD licensing specialist or the local public health. It's, you would refer them back to their licensing specialist, and they know who that is.
Yes.
But it is a good question, because this comes up a lot because people get confused about contacts of contacts. So the basic rule of thumb is that you don't have to quarantine unless you were directly exposed. A person who is a contact, they have a household member at home who has COVID, and so a child is then a contact. They are not infectious, and so we, unfortunately, there may be a period where they might be infectious and we don't know about it because they haven't been tested or they haven't become symptomatic yet. But in general, we will presume that the contact is not infectious and the whole class doesn't need to stay home. It's only if the infectious person was in the daycare where they, potentially expose a whole class and then require a class to go home.
And I do want to go back real quick to the previous slide with the exclusion chart. I just wanted to let you know that we have included that exclusion chart in our list of documents that we've provided to support you. So along with the slides, we've sent the exclusion chart, and we also wrote up a list of frequently asked questions that we received that we think are going to be helpful for you. Okay, next question. Just one sec here, my PowerPoint is. Okay, so within the context of childcare, when you're talking to especially a center director, you might hear the idea of a floater staff or a substitute or volunteer. So floater staff are staff that are typically kind of their extra staff person that they have float around to different classrooms to help cover breaks. And we have encouraged and tried to have them keep those staff at a minimum, because if one classroom gets infected and a floater staff is involved in it, every classroom that floater's been going to then has to go into quarantine. So you might hear that in the course of your conversations. So the question is, if the floater sub volunteer tests positive, who needs to quarantine? And it's really anyone who was part of that stable group where those people were working. Now, we have recently put in guidelines that indicate that volunteers need to be assigned to just one group, that they can't be moving around to different groups. But a floater or a substitute provider that came in and worked in one childcare class one day and then the next childcare class the other day, then they would need to. And so where the conversation I think is going to go when you're talking to childcare directors about this is helping them determine the infectious period and whether that floater or that sub was in the classroom during those 2 days prior to becoming symptomatic or testing positive. But again, questions about actually closing down classrooms can and should be directed to the licensing specialist, who's going to help them make that determination. And Dr. Thomas, anything to add to that?
No, I think that's hopefully very clear. You can certainly take questions about it if anyone has any.
Okay. Okay, and Dr. Thomas, you want to take this one?
Yeah, so I think we covered this a little bit already, but it's good to sort of see it in writing for those of us who are visual learners. The idea is that, in household settings, if one person has COVID-19, that, you're continuously exposed to that household member for the whole 10 days of their infectious period. So the quorum period does not start until the day after the positive person's 10-day exclusion period ends. So the child then starts their 10 days of quarantine. So that would mean, really a full 20 days that they would be out of childcare. Unless, of course, other cases pop up in their family, and then it could sadly be even longer.
So we're going to transition our questions a little bit. As you probably have heard on the news, childcare providers became eligible for vaccinations this week. And as much as your line is not meant to be a vaccine FAQ, we do anticipate that you might get a few questions. So we wanted to support you and be prepared for that. So we're going to go through some vaccination questions that we're getting pretty frequently. Dr. Thomas?
Sure. So this one is about requiring staff to get a vaccination. And in general, I mean, the Oregon Health Authority, the governor's office, we are not requiring COVID-19 vaccinations for any group of people or in any workplace setting. However, individual employers might decide that they want to pursue this, and we basically refer them to this is a legal question, not something that OHA has any jurisdiction over. So we tell them they should contact the local office of the Bureau of Labor and Industry, and there's a website that you can refer them to.
And from a childcare regulatory perspective, we also are not requiring vaccinations of anybody. Okay, Dr. Thomas, the next slide was the table that you made, but I have both options for you if you prefer your revised one.
Well, why don't we start with the easier one? Because it can be a little complicated, but certainly we'll provide you with I think kind of the full one. So what's happening now is that, of course, people get their vaccine and they get reactions, and maybe that involves a fever. It's like, oh, but that's a COVID criteria. Do I have to stay home? And as healthcare workers, I mean, most of the time your employer sort of makes this decision for you, but for in childcare settings, or now the other group, that's the 1B group that's getting vaccinated, or school teachers, they may not have that ability to get that consultation from their employer. So we're trying to create kind of an algorithm that is more understandable to the general public about what might be a vaccine reaction versus what is most likely a COVID-19 infection. So kind of if you start on circle number one, or oval number one, the things that are most likely to be a vaccine reaction, and this is true just like in the first 48 hours after vaccine. If you have fatigue, chills, muscle ache, joint pain, or certainly pain or redness at the site of an injection, that's likely just to be either a local or it could be a systemic. It's chills or fatigue. Reaction, that's just a reaction to the vaccine. And generally, what we would say, if you're in box number one and you don't have a fever, you can go to work. A sore arm, you can go to work, as long as the individual feels well enough to work. I mean, I have anecdotally heard of friends who said, I had really terrible fatigue. I stayed in bed for 2 days. And really, if you feel like that, you should probably not be working. However, if a fever is present, we definitely want you to stay home until the fever resolves. Now, the right-hand box is the spectrum of most likely COVID-19 infection, and you would need to, it would need to be treated as if someone has had COVID. And I should say this is true if you've had either a first or second dose. If you have the cough, the shortness of breath, or loss of sense of taste or smell, that's really kind of COVID until proven otherwise. So for that one, it's excluded, and we recommend getting tested. Now, if it's positive, that's not due to the vaccine. And also, this is 2 days after if it's in the first 2 days after you're getting a shot, this is not COVID. You did not get COVID from the vaccine. I think that's a myth that has been perpetuated a long time about flu, which is not true. And again, these are inactivated vaccines. You won't get true COVID from this vaccine. But so if you have one of these kind of more respiratory symptoms, with or without fever, then that's kind of number three there. Then you stay home, you get tested, and we would sort of treat this like we already mentioned on our exclusion chart. If there's no tests done, or the test is positive, you go home for 10 days, and you have at least a 24-hour period of being symptom-free. If you do get a test, that's good. That can get you back to work. The probably uncommon situation is one person just has fever. That could just be a vaccine reaction. It could be signs of COVID, although usually the fever doesn't prevent first. And since, frankly, the vaccine reactions, given the number of people who are getting them now, or at least particular among this population in the next month, vaccine reactions are going to be more common than a COVID-19 infection. So if you have a fever only, we would say stay at home until the fever gets better. Now, if it's not better in 2 days, then you really probably should see a healthcare provider and think about getting tested. And certainly, if any of the other respiratory symptoms develop, then we would treat it as COVID. I think I have, maybe we could go back to the slide above it, which has more nuanced things about what to do. I think I have more like these little footnotes are sort of having to do is, this applies to people who are vaccinated in the past 3 days. If this happens 10 days after a shot and they're getting fever, fatigue, headache, chills, that again, that does put them more towards COVID. The other thing is this only applies to someone who has not had a COVID exposure in the last 14 days. So if they were exposed to someone last week, and now 5 days later they go in for their vaccine, it's like, well, I don't care if it's only fever or chills. It's like you're supposed to be in quarantine anyway. So, if you've been told that you need to be quarantined for 10 days, then getting a shot, like, and having a few fevers, it's like, that's probably a vaccine reaction. It's like, well, no, you're in quarantine. You need to stay in quarantine. And now these symptoms, these tend to again take this kind of over to the column on the right. If you're in quarantine, then you have to take this more seriously as potentially being symptoms of COVID. And then I think there's another footnote here on anaphylaxis. I didn't list that. It's not in my algorithm because it's not a common reaction, fortunately, but it is a very specific reaction to the vaccine, and we would not consider it as a likely sign of COVID. Again, COVID doesn't increase your chance of anaphylaxis. It would be a very unfortunate reaction, but it would be truly due to the vaccine and not consistent with a COVID-19 infection. So I think at this point I should probably stop and take some questions to see if this makes sense to people, because I feel like this is going to be coming up a lot. And I think there are, if anyone who does social media, we're seeing a lot of misconceptions about vaccine. So I think people are going to have questions about this.
And there are not any questions in the chat right now, but if anybody has a question, would like to take themselves off mute, they're welcome to. While we wait and see if any questions arise, I'm going to answer a question that is in the chat. And the question is about, are volunteers and subs in the education system included in the criteria for a vaccination? And when you say education system, I'm going to separate that out a little bit, because we have, the public private school teachers that are allowed to go get the vaccination now. And then on my side is the early childhood education system and the childcare system. So I'm going to answer it from the perspective of early childhood education. So substitutes, yes. Anybody who's working in the center and is, having contact with childcare children, including family members. So if we're talking about a family childcare provider and they have children in their home that are 16 to 18 years old, or their spouse, those individuals are eligible for the vaccine also, because they're having contact with childcare children. In terms of volunteers, that gets a little fuzzier. And when we have put out who qualifies for the vaccine, we've stayed a little bit vague, because it would be pretty hard for us to say, well, a volunteer who is there weekly qualifies, but one who only comes once a month does not qualify. So when we're talking to childcare programs, we remind them that we don't have enough vaccines to go around, that they need to make good choices about who they send for the vaccine, and they need to evaluate, how often they're using that volunteer, and is the volunteer essential to the childcare services. But we as Office of Child Care did not get into the nitty gritty about, you can send this person, but you can't send that person.
Again, I think this would be a question you could refer to the ELD specialist.
Yeah.
That's not really, that's out of the realm we expect you to do. I think the other question that comes up are more of these more privately employed nannies, where someone's hired someone just for their children, or these kind of school pods. We are not including them at this time. But again, that would be something you could refer to ELD.
So no questions have shown up in the chat. I'm going to pause real quick and see if anybody wants to speak up, because I do think having reactions to the vaccine are going to be things that you're going to get. Okay, Dr. Thomas, I think we must be pretty clear.
Wow, that's good, because I've been, no one else had really devised a quantitative kind of approach to the vaccine thing or not. So I'd kind of run it by the other senior health advisors, but it's good to test it with a medical crowd and see if it makes sense to them. So I appreciate your vetting it. And if you have any suggestions for, if you come up with any scenarios that you have encountered, please email us, because we'd be happy to hear about it.
Okay, Dr. Thomas, would you like to talk about the next
Okay, we
slide?
still have some more questions. Yeah, so this is really kind of the approach that you're hearing in the medical setting at this point. We don't know, the kind of the outcomes in all the vaccine trials was symptomatic illness with COVID-19. So it could still potentially be after you've been fully vaccinated that you might could potentially get a very mild, asymptomatic case of COVID and transmit to people. And especially now too, I think what we don't say so much is, again, it's 95% effective, but that means 5 out of every 100 people vaccinated might not develop an adequate immune response. And while we're still having widespread transmission, we would like everyone to wear a face covering, same as in the medical setting.
Okay, back to our previous slide, we did get a question.
Okay.
Receive feedback for rash as a reaction. I'm assuming you would want that to resolve for at least 24 hours.
Yeah, we haven't, it's not in sort of like CDC guidance, but we have anecdotally heard about, I know that, I kind of have heard of some rash. So I think, if there's any question, we would want them to stay home, for at least 24 hours. Certainly, the good thing about it is that, rash is not really, well, typically we don't think of rash as being a symptom of COVID, so it'd be more likely due to the vaccine. I think there is, of course, certainly in children and also kind of the multi-inflammatory syndrome in adults, that could be a bit more subtle, and that would be something that you would probably do a medical consult. If someone had a rash and was getting better after a day, it's probably not a big deal. If someone has a worsening rash and it's now day 3 after the vaccine, I think you would perhaps get a consult or refer them to their own provider. I'd be interested to see what Dr. Blaschke has to say about that one, since we have his expertise here.
He did.
I would.
Yep, go ahead.
I would agree. I think you might also think about chronic rash that might be exacerbated a little bit versus a totally new rash. And then I think talking to their healthcare providers, in theory, hives might be a minor reaction, I suppose.
Right.
But I think referring to the healthcare provider.
Yeah, and that really would need to be sort of, because certainly, even if the provider just sees a picture, they can, see hives and say that's a vaccine reaction, so that's an excellent point.
So one thing that was pointed out in the chat was that this one significant difference that they're seeing in our guidelines and is about the quarantine being 10 days rather than 14. So I did want to just address that we did have a 14-day quarantine for childcare right up until January 12th. And we worked with Oregon Health Authority when the CDC came out with revised recommendations that reduced quarantine to 10 days or 7 days if a test was taken during that 5 to 7 day period. So you might still hear that when childcare programs are calling, that they might still be referring to a 14-day quarantine.
Yeah, and the issue you should know about is that in general, we feel that the 10-day quarantine is pretty safe. And a lot of it, our decision to adopt the new CDC guidelines for 10 days was just frankly to help parents and providers, because families really struggle. Because as you can imagine, if we talked about the scenario of repeated infections in a household, if you were doing 14-day quarantines, it really stretches it out and creates difficulties for families. So we will accept the 10-day quarantine. However, you should know that in Oregon, the local public health authority, so the county health department, really does have final say in these matters. And in some counties, the health officers feel very strongly that they should still do a 14-day quarantine. And so county health departments get the final say. And so basically, if a provider calls you to say, well, we think we only need to do 10, but the county said 14, your response is, you need to, in general, you need to do what the county says because they're the authority. And if there are any kind of issues or someone wants to talk to someone about that, that again is not your problem. You refer them to their county or their ELD specialist. That's not something that you need to get in the middle of, but you should be aware that some counties might insist on a 14-day quarantine.
Okay, we have 2 more vaccine questions we're going to cover. So Dr. Thomas, if experiencing COVID-like symptoms, do individuals who have received both doses of COVID vaccine need to be excluded?
Yes, and unfortunately, we know that there will be what we call some breakthrough cases or vaccine failure cases where, again, no vaccine is 100% perfect. And so even after 2 doses, if a person has symptoms of COVID, you need to treat it like COVID. And again, so that's a 10-day exclusion. If they don't get tested or if they test positive, that means they have it. If they do get a negative test, they can return 24 hours after their symptoms get better. But hopefully these will be rare, but I mean, we are going to see them, and that's expected. We don't think that the vaccine, isn't working as well, but that's just kind of a sad fact. Hopefully this will become less and less common as we get more hurt, as the rest of the country gets vaccinated, and there'll just be less transmission, so it'll be less common. But I think in these first few months, we are going to see these cases.
Okay, our final question.
Okay, so this is the good news about quarantine, because I know it's certainly been a hot issue for healthcare workers, and certainly for other people who are essential workers who have jobs, where they have contact with the public on a daily basis. The quarantine has been very burdensome. And so at this point, if you've had both doses of the COVID vaccine and it's in at least 14 days have elapsed, then you're considered protected. And you would not need to quarantine if you're exposed to a confirmed case. You do still, because we know that there will be breakthrough cases, there is still a small chance that you would develop COVID-19 infection. So in that case, you kind of do like as you were always told. If you're exposed to someone, you do the symptom monitoring for 14 days, looking for cough, fever, shortness of breath, loss of sense of taste or smell. And then they would kind of go into the possible COVID-19 bucket that we just discussed. If you have these symptoms of COVID, then you'll be asked to stay home, tested, positive or not tested, you would stay home. If you get a negative test, great, you come back to work.
Okay, well, that is it for today. Any final questions before we sign off? I think we are
One more quick comment. I didn't think of this in advance of the training, but yes, early in the pandemic, we were getting lots of questions from daycares via parents to get a form that their fever was due to their regular shots. So we might think about adding that. The approach is just the same as with COVID-19 vaccines. If there's no other symptoms within 48 hours of routine vaccines, they don't need to be tested just because of that fever. The exposure question, like Dr. Ann covered, is the question to think about. And then I'll just add too, I put this in the comments, that the loss of taste or smell is not something that you will often hear from very young kids.
Right.
It will be helpful in teenagers and maybe older kids. But in very young kids, their taste and smell, if they lose it, might affect their appetite and their eating. Yeah. But there are lots of reasons for that to happen as well. So I wouldn't test every kid who has a change in their appetite and eating. The loss of taste and smell is most helpful in the verbal kids.
Yeah, I have to say, we first developed guidelines last summer. I felt like it was silly to even include that. So we just had fever, cough, shortness of breath. But where it comes into play is that the school guidelines do have that loss of sense of taste or smell, which makes sense because they're older for most children. And we would always be getting questions from families like, well, one child is excluded for this, but then they're not excluded from childcare. And where it really comes into play is that many schools will have on-site before school and after school care. And those are licensed by the early learning division. So they would follow these childcare guidelines. So we actually had different criteria, and it threw people off. So in general, we've kind of had to come in line and make all of our guidelines, for the most part, pretty consistent with the Office of Department of Education. So I agree, it's not a great criteria.
Yeah,
you know,
completely
infants
agree.
and
And
toddlers.
the only reason I completely agree and understand, the only reason I bring it up with this group is because we are talking to RNs and the medical reasoning, right? So, if a kid really had a dramatic change and some fever, yeah, it might trigger my brain in a young kid. But I get it. It's for being consistent across all of education and after school programs. It's just not something that nurses will hear from young kids.
Yeah.
Okay, well, I think we are done for today. Thank you so much for your great, oh, wait a minute. Another question came in. Would they need to have a provider note to okay them to return to school if fever is determined to be vaccine related? Dr. Thomas?
At that point, we are not, well, I think the thing is, because at this point, we're not vaccinating children. This will come up in adults. And I think in general, at this point, we have not said that they would need a note from their doctor.
No, I think what she's referring to, Anne, is if they have their routine childhood vaccinations.
Oh, okay.
And then they have a fever and they're excluded, because they have a fever for 48 hours. Ideally, the care centers would not require a note for routine vaccines.
Yeah. So we should just add that into our, maybe add a slide onto our, because I don't know, has that actually come up so much, Tammy?
Well, I haven't heard that, but what I can say is our guidelines do require for fever that they have to have a doctor's note, because the childcare provider isn't in a position to say, oh, you just had a vaccination. It really does need to be a doctor that is providing that confirmation.
Okay, so our answer is they would need a note. Yeah.
Okay, we can set something up for that. Because it might be something even that the call center could just provide. They're obviously not returning to school with a fever, but they were gone for 48 hours because of a single fever. And I get it. We can work around that.
Yeah.
Yeah, and our guidance does just say a medical professional can provide the documented advice that they can return to care. Because without that, a child care provider just doesn't have anything to go off of.
Yeah.
Okay. And some
Perfect, Charlie. I think we can do the same for kids.
Yeah. I see Julie commented that they would want them to get that from their primary care physician, primary care provider. I'll let you guys work out those details.
Yeah, I mean, ideally, providers should do that. I mean, because they're the one, they're giving the shot, they have all the documentation, although I suppose, do the telehealth providers actually have access to alert the state immunization registry? Would they be able to verify?
That's the problem. C4 doesn't know how to do that.
Okay, yeah.
That's why I want them to refer. Yeah, no, I don't even want to touch that with a 10-foot pole. So that's why I want them to go back to their PCP for that information, because it's all hearsay. And the C4 nurses are now taking ownership of adults who are getting the vaccine and have to miss work for a couple of days. They are now allowed to write the employer letters that their employee had side effects from COVID for the last 48 hours, and that's why they had missed work. I don't want to put too much work on the C4 because of all the other responsibilities they have. So I would really like them to defer this letter, if they need a letter, to refer them back to the PCP, because the PCP can address exactly what kind of vaccines there were that the child had.
Yeah, I think that makes sense, because as it is, we're already saying, like, you know, the criteria that will get your child back into childcare is, you know, if they have a fever, get a note from your doctor. So it makes sense, like, well, if they have a fever because they got a vaccine, like, that provider should be able to write a note.
Thank you.
Okay, well, I will be sending this recording so that you guys have access to it, because I know you're going to want to sit around in the evening and listen to it repeatedly. So thank you very much for your time, and hope you have a good rest of your day.
Thanks, Tammy. Thanks, Dr. Thomas. Appreciate it.
You're welcome.
I'll see you on next Wednesday.
Yes, we
Okay,
will.
great. Thanks, everybody.
Bye-bye. Have a great weekend.